Well, Howard, would you like to start?
Okay.
All right.
Okay, I'll start with this case. I'm not really sure that the patient's symptoms or the presentation has to do with the observation. But the patient was seen at a clinic, and I'm not entirely sure what the presentation was. I don't think it was any kind of acute febrile illness or anything like that. So, of course, an observation is made of this rounded opacity in the peripheral right hemithorax, for which, not surprisingly, further evaluation was performed. So let me show you the CT, and you'll get an idea of its location and its attenuation characteristics. It clearly has some dystrophic calcium associated with it, mostly in the periphery, pleural-based, or at least close to a pleural surface. As you see there, and I'm not revealing any history, which when I looked at the medical record, we didn't have, and I wonder if the history was secured after the lesion was removed. So I'm not sure, just based on the imaging alone, what differential to give. It's a solid lesion. It's got peripheral calcium. I suppose one would reasonably think of things like a fibrous tumor of lung or pleura. I'm not quite sure what else in particular. I'm not suggestive of any particular thing. So, of course, the pathology is by far the most interesting part of the case. So here are images from what was removed. And you can see here that it is a rounded thing, and I'll show you the contents of it in a moment, but the pathologist got quite excited. So here is that round thing, and then you get an idea of the contents looking like that. Let me just go forward to show you that this is the contents. And if I go back to histology, you'll see on an image like that, there's some polarizable stuff there. And you look at the structure of this piece of stuff like that. Really interesting. So, of course, the key here is the history, which I'll put up over here. So the past history was 22 years ago, trauma, riding a dirt bike, a tree branch pierced his right chest. And of course, what we're seeing in part is some of the branch that remained in the chest. Recalls removal of it, but obviously not all of it, and then it healed. And here you can see some details about the surgery. So I've decided to call this kind of a timber thorax, or arbor thorax, tree branch remaining in the chest. I remember that Jeff showed a case once of a person that was in Wisconsin canoeing and had a tree limb also penetrate his chest, right?
Yeah, it was a kayaker, and he was
Kayak.
wearing a life vest, and so he had a branch. Same thing, it broke off. It was much smaller than yours, and he developed a lung abscess. And they had to, because it wouldn't heal, they resected it and found smaller bits of cell walls in there. That's amazing. So
That's quite impressive, isn't it?
did the pathologist describe like the type of inflammation around it? Was it granulomatous, foreign body type, or?
Let me see if I have any excerpt of the actual report. Um,
Is it,
oh, I think I had it, but maybe I didn't put it there.
it just seems
But
like it's very solid looking. I mean, there's a lot of tissue
yeah,
to this thing.
yeah, it's interesting that when they saw that there was some fluid within it.
Hmm.
So that sort of cavity part was partly fluid
So it looks
and
like,
partly pieces of wood.
yeah, so it looks like it may have been chronically infected based on the description from the surgeon that you're showing.
Yeah, or it's certainly inflamed.
Wow, that's
Yeah,
amazing. And you said
it's
it's
quite,
22 years beforehand this happened?
yeah, yeah.
Yeah, I called mine an arbothorax as well.
Huh.
or lignothorax.
Ligno, I have to look at that. Ligno. Is ligno for ligneous? Is it got to do with wood?
Yeah.
Ligno?
Right.
Oh, I like that. Timber doesn't sound right. Lignothorax. I like that. That's very nice.
I thought
So
you were
I'm
going to
not
say
sure.
about to get the word splinter in there, something like this is like a bad splinter.
Yeah. So that's a cute case. Again, I'm not sure that his symptoms were actually related to this. It's lived with it so long. So that was really quite interesting.
Indeed.
Here's a really nice case. This one's anatomy lesson. So let me show you a representative images of frontal and lateral. And the finding that's interesting is not related to the cardiac surgery. We see a valve, cabbage, but the finding that's really interesting is related to this right here. So here on the frontal projection, we have that triangular shaped opacity. And then if you look for some corresponding opacity on the lateral projection, you can perceive there is something over here. So let me just bring up representative slabs just to give you a feel for number one, that one right there, and its relationship to the fissure. On the lateral, you can see where that opacity is and its relationship to fissures. So now I'm going to tell you that this appearance, this triangular shaped thing, is sometimes described in some cases of right middle lobe collapse, which this is, when you obtain a lordotic projection of the chest. It's unusual to see this triangular shaped opacity on a non-lordotic projection of the chest. So let me show you here in this classic article about right middle lobe collapse that with a lordotic projection of the chest and right middle lobe collapse, what you might see, and let me go and bring up one of these frontal projections again. And now I'm going to kind of zoom in there. The first thing that's interesting that was described is a wedge within a wedge appearance. And here they describe two wedges, one here, and this one depicts another wedge. And this wedge over here is continuous with an interlobar fissure. So on this side, I'm going to indicate first the bigger wedge, which is something like that, right there, would represent the bigger wedge. And I'll make that go away. And then I'll indicate the smaller wedge within, which is sort of right there. You can kind of make out there might be two wedges in here. And this wedge here that I'm indicating appears to be continuous with the major fissure. So I think there's a very nice correspondence between this image here and what we see there. So this is the middle lobe, right upper, right lower, where the right upper and the right lower meet, because here the right lower lobe is particularly expanded, make the fissure, which is the major fissure. So we have minor and we have major fissure. And then this is a nice article about collapse on CT from the 1980s. What I need to do is find the right middle lobe, so-called tipped up variant of right middle lobe that you see here, which is here. So this is the so-called tipped up right middle lobe, where without a lordotic projection, you can see the triangular opacity of the lobe because the right lower lobe in particular is more expanded, taking up quite a bit of room and lifting the lobe up, as it were. So super nice example of some anatomy and the tipped up variant of right middle lobe collapse, like that. In this person, this is a chronic thing. It was thought to be due to perhaps aspergillus or ABPA. I'm not really sure, but this is not obstructive atelectasis, but some form of cicatrization atelectasis. Oh, I didn't show you the right middle lobe properly, but there it is here. And the bronchi here are patent, maybe a bit narrowed, but there's chronic right middle lobe atelectasis there on that frontal projection right there, making up this appearance. So some nice anatomy.
Mm-hmm. Very nice.
Yeah.
I was not familiar with that sign, the wedge within a wedge. I guess we don't do too many lordotic projections anymore.
Exactly. So, I mean, these guys, this is the classic proto-article. Those guys were really fantastic anatomists in the pre-CT era.
Mm-hmm.
This goes back to the 1980s and before. They made great observations. All right, let me show you this one. Very interesting case. So a person comes into the ER short of breath, not sure exactly what other symptoms, and to no one's surprise, one of the things they did subsequently was the CT, which I'll show you. This is the kind of radiograph where it's really hard to describe. You sort of sense that maybe the lungs are not really normal, but one sees the vessels quite nicely. So perhaps there's ill-defined opacities in the lungs. And there are indeed, because the CT was obtained just a little while later. No PE, but you'll see, sorry about that, let me bring that back, that we have very extensive diffuse multilobar, confluent ground glass, and to a lesser extent some consolidative opacities making that up. As you can see, they're pretty dramatic actually. And the history and everything else that goes along with this is key because you can't make the diagnosis unless you have this additional information. So here is the information. This is a case in which we have acute eosinophilic pneumonia. So we have 9.5% EOs in the blood. We have 70% EOs in bronchial lavage. And because he had this drug called naltrexone sometime before, it was ascribed to naltrexone in the absence of any other potential etiology. So naltrexone is sometimes given to people with drug abuse. It's supposed to reduce, for example, the euphoric effects of opioids and opioid kind of antagonists. And I did find, this is from the FDA package labeling for the drug Vivitrol, that here is a portion of it that I just did a screenshot. And in the trials, there was one diagnosed case and one suspected case of eosinophilic pneumonia attributed to this. So whether it's the actual molecule or something in the formulation that produces that. So this patient did pretty well. They took the drug off, gave him steroids. Here is a follow-up. His chest radiograph looks very nice now, all healed up, and presumably they won't try the naltrexone again. So a nice case of that. It seems like in the last couple of months, quite a few of us have shown eosinophilic pneumonia, some of which related to drugs, I think.
Yes.
And then others idiopathic, yeah. Okay, let me show you just an incidental observation. So the finding on this CT are the nodes. Now they're not enlarged, but look how attenuating these nodes are. All the hilar, infrahilar, intrapulmonary, and some mediastinal nodes are really quite attenuating. So if I were to do this, maybe I'll just bring this up over here and put a cursor there. There we have 172 Hounsfield units. And here we have 115. They're around 98. But just looking at them, they're very attenuating nodes. Everything else looks okay. If you look at the lungs, they look fine. And the history here, and this is probably the cause, is that he is a welder. So he spent some time in oil pipes, welding in enclosed spaces. So presumably he inhales metal particles, metal molecules, and his macrophages, lymphatics, put them into lymph nodes. But the lungs look fine. So we attribute this to his occupation. Metal, high attenuation, metallic stuff.
Jeff, Jeff, you sent a case years ago of luminosis with very bright nodes.
Yes, I was just pulling them up. I actually have two, and we also see this with coal and silica. And what it reflects is the lungs, pulmonary lymphatics doing their job and clearing the dust, and it accumulates in the lymphatics. I think it's only when the lymphatics are overwhelmed that you start seeing simple pneumoconiosis.
Yeah, very nice case. Exactly.
Yeah. I'll quickly show one. I have one image here, Howard.
Go
Okay,
ahead.
sure.
I was going to show.
Yeah, go ahead.
Yeah, hold
That's
on.
my last.
There, let's see. You see, this is a case of an aluminum filter. Same principle.
Similar.
And there were no underlying lung nodules. So yeah, it's kind of cool. So that's important, I think, when you're looking at cases of perilymphatic nodules and you may not have the history if you're trying to distinguish from sarcoid, because sarcoid you tend to get the central sort of icing sugar look to it early on, and then as it progressively calcifies, you get more of the chunkier calcification. Once you have eggshell, it's a little more challenging. But you can imagine with your pattern there, if it continued on, you could get some thicker calcification. And sometimes those lymph nodes have milk of calcium centrally and denser calcium in the periphery.
Howard, is this still your case that's showing?
Yeah, this is my case, yeah.
Was there anything out in the peripheral, subpleural regions of the upper lobes? Because in the sort of co-worker's case that Jeff is describing, I've often seen these high attenuation collections immediately subpleural in upper lungs. And I think that's the lymphatics carrying the stuff out to the edges of the lung, depositing it out there. Have you seen that, Jeff? The subpleural sort of pseudoplaque distribution? Jeff, I've lost your sound. Are you still on?
Yeah, I'm here. Sorry, I was on mute. Yes, I have seen that in very early dust exposure.
Very cool, Howard.
That is great. Yeah, and that's a welder. Yeah, I think I've seen it in a welder too. Excellent.
All righty, Jeff, those are my cases for...
All right. David?
I would be happy to show you a couple of cases. Can people see a radiograph?
Yep.
Yes.
So this fellow has leukemia and has had chemotherapy, and they've been unable to achieve a remission, but he has no white count. He really has no white cells at all. And his radiograph last month showed this new nodule here in the right mid lung. And a couple of days later, this is about 12 days later, you can see that he's got now a pretty big right upper lung consolidation, maybe the follow-up of what was a smaller nodule down here. Plus he's got this nice lesion over here with a hint of lucency in the center. And on CT around that time, he indeed has a very nice bird's nest pattern in upper lung here. I think he was on an anti-aspergillus suppression regime. But this came through, and with a bird's nest pattern like this, a strong contender, especially in somebody who's being protected to some degree against aspergillus, would be mucor. And this is indeed a case of mucor. It was an unusual organism name, which I'll have to write down and send you guys when I post this case. But excuse me. just aspirated edamame. So this was proved at lavage to be a zygomycete on both sides. And he's got a little bit of the bird's nest, a little hint of the bird's nest pattern on the right as well. But he's he's still alive after a couple of weeks, but he is declining. Normally this progresses much faster than it did in him. For a while it seemed as if he stabilized on amphotericin, but things have eventually caught up with him, and his current radiograph is here. You can see with larger consolidation on both sides and decreasing lung volume and increasing pleural effusion. So as of a CT this morning, he's continues to get worse at a slow rate. So probably not much can be done, given that his counts can't be restored, and it's unusual to clear this infection unless you have some white cells. So as zygomycete, I'll give you the species name when I post it, the case.
Okay. But
a very nice bird's nest pattern. So that bird's nest sign really holds up pretty well in establishing the diagnosis of strongly suggesting a mucor rather than aspergillus. And then here's an industrial exposure. This fellow has this diffuse fine nodular pattern here. This is an outside case, and he's looked like this for a couple of years with this diffuse lung disease. And let me show you what it looks like on CT on him. It seems to be I think a fine nodular pattern. Here you can make out individual nodules in this sarcoid-like peripheral distribution, subpleural distribution. Things get kind of lacy and stringy here. It's hard to recognize and to be sure that this is fine nodules arranged in lines versus more of a reticular pattern. He was biopsied, and he did have, but we've not been able to get the results. And I think the biopsy was done for something else. And so we have not established that this is a granulomatous process, which I suspect it is. He had a beryllium sensitization test, and that was positive. So this is probably berylliosis in this fellow. You kind of wonder if there's some calcium in it mixed there, but that could just be an artifact. And then he's got some modest mediastinal lymphadenopathy, nothing particularly striking here, nothing that you would look at and say, oh, that's a sarcoid-like pattern. That would also support the idea of berylliosis. So this disease has been there for years. It hasn't changed very much, and it looks most like sarcoid to me, and I think this all fits with the beryllium sensitization that he has. This is probably berylliosis. He was in a work environment where there was beryllium exposure. I think he's part of nuclear construction at nuclear sites. Okay, so I presume berylliosis in this gentleman.
Excellent.
So those are my cases.
Okay.
David, I was going to comment about your first cases. I'm trying to recall if I've seen a case of bilateral mucor. Usually you get a single large infarcting looking mass and maybe some satellites, but I don't recall seeing that extensive bilateral lung disease. That's because sometimes they have to resect it because they can't clear it.
Right, and but they can't resect it if it's in more than one place. And we have, I'm sure, seen cases where it was in more than one lobe. So, I'll flip through my zygomycete cases and see if how often they're just one focus.
Yeah, or at least bilateral. Yeah, that's interesting. Okay. All right. Let's see, and I've got 3 cases I can share here. All right, I'm going to start with this case. You should see a frontal radiograph.
Good.
All right, so this is a young man. He's about 19 years old, if I recall, but 18 or 19. And he presents with sort of fever, weight loss, and a cough. And he has this radiograph. And you can see on it there is a mass that has some holes in it. The lateral radiograph localizes it to the right upper lobe anteriorly. And he underwent a CT scan to further evaluate said mass. And you'll notice early on we see several really well-formed nodules. Got one here. So very well circumscribed nodules. And then here's the mass in question, and it's got a very thick wall, a lot of internal debris, no real fluid level. And again, some more well-defined nodules that are just kind of randomly distributed. So if I saw this in an older patient,
some Cheerios.
yeah,
Do we have?
yes, we have a Cheerio. I think there's one in the, where was it? And this one's got a little faint lucency in it. But when but not the best Cheerios. Maybe some soggy Cheerios or Cheerios with milk. There's one right there. So, an older patient, you would favor this being ugly lung cancer with metastases, or maybe renal cell or something hematogenous. But he's a young guy and doesn't have a good history, but maybe something infectious. Blastomycosis where we live could definitely give you a mass like this, although the edges usually are much shaggier, and I wouldn't expect to see the well-formed nodules. I'd see more inflammatory type nodules. Mycobacterial disease, I don't like it for tuberculosis either. Again, it's too clean on the outside, and I'd like to see some more airway-centered inflammatory nodules. So it turns out not a lot of other things left on the list. I mean, those would be the most likely, but he had some sinusitis, like stuffy nose, bloody nose every so often. And then on his evaluation, he's also noted to have a slightly abnormal BUN and creatinine. And so they worked up his kidneys as well, and he has a glomerulonephritis. So this is pardon the truck noise on the outside there. This is a presenting case of granulomatosis with polyangiitis. And he is Caucasian, as most of these patients are. He's kind of on the younger end. I have seen it in teenagers and young adults, but we typically see it in a little bit older patients. And is going to undergo treatment with immune suppression for this. So it has the typical cavitary look I'm familiar with GPA. They're very ugly, very thick walled. The nodules tend to cavitate rather quickly, and as they get bigger, the majority of them will be cavitary. And sort of the more well-formed ones when they're smaller. And these are all areas of necrotizing vasculitis and necrosis, hence the sloughed lung.
And his airway was nice and smooth, right? No airway.
Yeah, he did not have airway involvement, which, it's interesting. I used to see a lot more of that, and I don't see a lot of GPA anymore, but the few cases we see a year, I've not seen nearly as many cases with airway disease. So I don't know if why that is, or if it's just a sampling error of a smaller number of cases. Okay, this next case
might be chronicity. Maybe those Cleveland Clinic cases were the ones that were referred, down the line.
Yes, it was a large vasculitis clinic, so maybe so. Because you're right, you typically see that later on in the disease. Now, this is an interesting case from a sort of imaging morphology appearance. So I'm going to start back with the original CT scan. So this patient, older patient, came in. This was in the emergency department at another institution with some chest pain and had a CT angiogram. There was no pulmonary embolism, but the report acknowledged this sort of branching nodule structure in the middle lobe. And we can see it doesn't really have an air bronchogram in it, but it's along a bronchovascular bundle, and was described as maybe infectious or inflammatory. But the radiologists, I think, correctly given they didn't have a lot of information, recommended a surveillance scan. I will point out the vessels around it look a little plump as well. So this was in October of the year of presentation, and now we're going to fast forward to January. So the 6-month follow-up was adhered to. And at this time, this was done elsewhere as well. This was the follow-up CT, and you'll notice that it has gotten a lot bigger. And there's sort of this nodularity around it, sort of these branching structures. So almost looks like an obstructed airway. So raise the question of infection, particularly mycobacterial disease, given the chronicity. Maybe a non-tuberculous mycobacteria would be more common. You can see there is an airway going right near it. So at this point, it was suggested the patient see a pulmonologist, which they got scheduled for, and then they went for another CT. So now we're fast forwarding 4 more months, and then I'll put them up all side by side. And in that 4 month period, that little branching thing became this large, ugly mass. And there's also now new subcarinal and right hilar lymphadenopathy, also lower paratracheal and upper paratracheal. Bad shoulder.
Yeah. Jeffy had pericardial effusion on the previous CT too. So.
Yes. And there's his pericardial effusion. And the pericardial effusion, if I remember, was not an acute thing. So he may have had pericarditis at the time, and maybe some left heart disease, had some pleural effusion as well. But I'm really interested in this lung because I have never seen, I'm going to get these in order here, seen this presentation of this pathology. So this is the newest scan. I think I got to switch these two. Yeah, here was the original presentation. So I got them out of order. Let's see. So this was the original follow-up and subsequent. So this was biopsied and came back as small cell lung cancer. And so I was presented with the case by the consultant after the PET CT was done. And you can see there's the mass, and there's uptake in the nodes. So it's a limited stage small cell at this point, but there is nodal involvement. And it actually, for a small cell, it moved pretty slowly, considering it presented back in October. But so, what I want to show is I went back, knowing again what we were dealing with, and looked very carefully at this outside CT, at this original presentation, and trying to decide, can I distinguish this from an airway lesion? I don't have unfortunately, I need the sharp images. There we go. And I can't follow an airway into it at this point because the airways are too far. They're normal, so we don't see one. But we see endobronchial stuff all the time. But I did sort of point out that the vessels in the vicinity were a little dilated, which I think in retrospect is appreciated. But going prospectively, that would be a very hard observation to make and distinguish this from airway dilation. And then if we look at the first surveillance scan that was done a few months later when it started to grow, you follow that airway in, but the airway almost fades into it. I can't tell if it's abruptly cut off or if it is just disappearing, but the shagginess of the vessels around it bothers me, and it was reminiscent of cases of endovascular metastases I've seen in renal cells. You see a fair amount of renal cell and a fair amount of these types of metastases. So I start seeing dilation of the veins when you can start seeing these little side branches that normally aren't even visible, suggesting there's an obstructive process there. And then just to the final presentation, when it was a very large mass, clearly you can see the dilated vessels coming out of the mass, and here's this vein, and you see the side branches and all these dilated vessels around it. So I think my theory is this started as an endovascular small cell or adjacent to a vessel and promptly invaded it. But it's one of the unusual small cells in that it presents in the lung periphery as a nodule or whatever you want to call a mass now, as opposed to a central mediastinal mass.
Very odd. Very odd.
Jeff, are the pathologists pretty confident that this is a lung primary and not some other unusual tumor that has small cells? Is it TTF positive and all that?
I don't remember that specifically, but small cells aren't always TTF positive. They're usually synaptophysin and chromogranin, which just tells them it's neuroendocrine. But the PET did not show any extrathoracic disease. So I think the PET is pretty definitive, and it started as a lung nodule that grew. I mean, small cell looks like small cell, and I don't think you can always distinguish it, the location of it. I've seen a few small cells that were extrathoracic, where we're staging, but the lack of disease elsewhere, I think, really makes this a lung primary. It's just, it's about 10% of small cells can present as a lung nodule. We've resected a few inadvertently, because you biopsy them and there's malignant cells, but it's unclear what it is, and it's a stage 1, so they take it out, and the final path comes back as a small cell. And it's always kind of controversial what you do with them. The thought is you still give them chemotherapy, which is a different regimen. It's usually platinum and then etoposide. So we use cisplatin and etoposide for small cell, whereas with non-small cell, of course, there's a whole different regimen. And then there's always the debate about the brain. Staging brain MRI in this patient was negative, but many of them get treated with prophylactic radiation. In this case, given the lymph node involvement, they almost certainly would. But had it been sampled earlier on, which I don't think necessarily would have been done. I mean, I think it was handled appropriately. A follow-up showed an abnormality. It was recommended to pursue it. It's just there was a delay from the time of the imaging to, the patient was put in the queue for a consultation. It was referred to us to look at, and for just a lung nodule, it wasn't really suspected it was malignant at the time. But you always, but as far as it goes, I think had it been biopsied earlier when it was just a little nodule, I don't know what they would have done short of chemo radiation, and the brain's always in doubt. But this is probably the oddest small cell I think I've encountered.
It is very odd. I don't know what to make of that.
Yeah, because I was asked to review the case, curious if there was anything about it earlier on that screamed malignancy, and not really. Nope. Not until I started really dissecting the images, but even then I still would have favored it being a non-tuberculous mycobacterial process or some other infectious type thing. Okay, and then my last case is it's a good teaching case for a variety of reasons. So let's see, you probably don't see, you should see a portable radiograph.
Good.
So this is an elderly patient who has chronic heart disease and had some trauma and had a pleural effusion and had this drain placed for the pleural effusion. You see there's some lobar atelectasis, maybe some edema. And this was done the morning of the day that this radiograph was done, and everything looked fine. Later that afternoon, they had pulled the drain out, but the patient was becoming progressively short of breath, and I will put the two up side by side. So one of the things I always teach my junior residents is when you see new pleural effusion, especially very quickly, one of the things you have to think about is blood, especially after surgery. And we'll notice a couple of things. First of all, there clearly is a pleural interface out laterally, but there's also now displacement of the heart and mediastinum. We see the aortic arch is now superimposed over the spine, and you'll see it's a fairly well-centered radiograph. So this isn't just a rotation. And the right heart border and the right interlobar pulmonary artery and hilar structures are also displaced. So even though we see this crescent here, there is clearly some space-occupying process, yet we still have some lobar atelectasis. So very concerned following a drain release that there's now a hemothorax, and we've got there's some of the rib fractures and such. So a CT was done shortly thereafter. Patient was continuing to become short of breath. That confirms, and between the two, they had actually put a straight pleural drain in, which retrieved blood. But you can see that as we go down, this is a heterogeneous, dense collection, and there's some pooling of contrast. And right there, you can see a little bit of a blush coming right into the chest wall, right where this intercostal artery is. And the resident also who was on call that evening had requested some delayed images, which you can see that there's the blood pooling down in the pleural space. So we have a hemothorax that developed following a tube removal with clear intercostal artery hemorrhage. Now, I think what's the other important teaching point for some of the more experienced people is that we learn when we do thoracenteses or lung biopsies or even back in anatomy, that the intercostal arteries typically, they live in the groove underneath the rib, especially. But as you get older, what happens is those arteries become more tortuous if you have patients with systemic hypertension. And you can see, and this was the artery in question. So there's the blush, and this is a coronal MIP I made, and you can see it almost looks like a sine wave here, but you can see how far down this artery can dip. So even if you're going in the intercostal space on the lower half, it is possible sometimes to injure a vessel with that, especially when you're putting in, say, something larger than a 20 gauge needle, like a drain or a trocar for a drain. It is possible to injure one of these. Like this, if you look here on the right, clearly that artery is right sitting on top of the bone. So they're at increased risk. So, always, I always, when I was doing biopsies, I always preferred an anterior approach, because if you go anteriorly, you'll notice as we move anteriorly, the intercostal arteries become much, much smaller. See, they're much smaller here. And as you come to the front of the chest, you don't even really see them. It's much more internal mammary blood flow with very small branches that run under the artery that are sometimes below the resolution of CT unless you've got really intense contrast. But you can usually resolve a 1 or 2 millimeter vessel, but you just don't see any visible intercostal arteries anteriorly. So important when doing these interventions to sort of be aware of that, and we really have to hug the periosteum on the upper surface, but it's always a possibility. But in older patients in particular, these tortuous vessels can be quite impressive.
Did they observe the patient and the bleeding to stop?
Well, yeah, you can. I mean, also draining the hemothorax can be helpful too. In this case, they actually went and embolized the intercostal artery.
Wow.
Yeah, you can pretty much embolize anything in the chest wall with impunity since there's such good collateral flow. But yeah, this was one of our this was one of the bigger bleeds I've seen. But it was interesting because there was no problem as long as the drain was in. So it must have been either tamponaded, injured going in, and it sort of was auto tamponaded, or it was injured on the way out. But typically, you release the pigtail and it just the tract. It had been in there a few days, so it wasn't a really mature tract, but usually they slide right out. But it's just an unfortunate complication, but one you have to be aware of. And the team was very, I think, noticed the patient wasn't doing well and wisely chose to re-image the chest, thinking maybe there was a pneumothorax, but in this case, actually a hemothorax. But for the junior people watching, rapidly developing pleural effusion is typically blood and not just serous fluid from heart failure. It takes a little bit more time for that. Okay, well, that is what I have.
Excellent.
Very good.
Yeah,
Jeff, would you post that luminosis case as well when you put stuff up?
Yeah, I will for sure.
That was super. Thanks, everyone.
Yeah, great cases today.
Thanks, everyone. Great.
All right, are people around next week?
Yep.